Great. So welcome everyone to the first Speakership event being hosted by your Cano BC chapter executive. Very delighted today to welcome Dr. Kristen Haase from the UBC School of Nursing, who is going to be presenting out on her work today. But before we get rolling too far, I almost forgot. I do just want to acknowledge that I'm speaking to you today on the land on which I live, work, and play, which is the traditional, ancestral, and territorial lands of the Silex Okanagan people. And I think I just want to acknowledge that given the recent events that I think everyone has heard about across the country with the discovery of those 215 unmarked graves at the Kamloops Residential School. So that being said, I will hand it over to Kristen now, and I'll let you introduce yourself, Kristen, and look forward to hearing about your work.
Thanks, Andrea. Thanks, Andrea, and thanks everyone for coming today, and thanks for the invitation. I appreciate it. Today, I'm going to be talking about supporting self-management for older adults with cancer. So I'll be presenting some evidence and opportunities. So my name is Kristen Haase. I'm an assistant professor at UBC and new to UBC. Prior to this, I was at the University of Saskatchewan. And I think that's just important to talk about because some of the work that I'll be talking about today was developed while I was there. And so I'm kind of in this bit of a space right now of transition. So I'm happy to share this work with you and talk about how it relates to the BC context. And I just want to start off also by echoing that I am on the traditional, ancestral, and unceded territory of the Musqueam people. I started this work on Treaty 6 territory. That's where I grew up in Saskatchewan. And, you know, I think this week has given us all an opportunity just to reflect on all of our roles as myself, I'm a settler, on our need to sort of engage in that process of reconciliation and go back to that, the guidelines that have come out already about what we can be doing and what actions we can take. So I think it's great that we're all sort of taking this pause to reflect on that. So I also want to acknowledge today my collaborators. This isn't an exhaustive list, but just some key folks who have been involved in the work that I'm going to talk about today. At the top of the list, and very importantly, I would like to acknowledge my patient co-researcher, Margaret Thompson, as well as Dr. Schroeder Sotar, Shahid Ahmed, Doris Howell, Dr. Martine Putz, and Stephen Hall. And I'm not sure why I didn't put Doris Howell's doctor in front of her name, but just to point that out, and also acknowledge the participants in the research as well. And funding for this work was from the Saskatchewan Health Research Foundation and the Saskatchewan Centre for Patient-Oriented Research. So my plan for today is to give some background about older adults and their distinctness and why I'm interested in the topic of self-management, to discuss the research evidence that is building towards some of the work I'm working on now, and then also to provide some time for discussion and really hear your thoughts about self-management in older adults with cancer. And I know we probably have an hour, but I would never be able to talk for that long. So I'm really happy to, you know, I'll probably talk for about 25 minutes and then have time for discussion and engagement. So that is my plan. If folks have questions or concerns, feel free to enter them in the chat. And I would just ask that, Andrea, if there's anything that comes up, feel free to stop me at any time. Thanks. So I think we all know or are somewhat aware that the majority of cancer diagnoses occur amongst those who are older than the age of 60. And that's supported by our Canadian cancer statistics that tell us that that actually is 90% of all cancer diagnoses. In BC, what does this mean for us? It means that 75% of new cancer diagnosis in 2021, so this is a projection, will be in older adults, so those over the age of 60, and 20% will be in those over the age of 80 years old. But who are older adults? And I think this is always an important conversation, and this is something that when I present on this work, someone who's like 65 in the audience will always say, but I'm not old, I'm not an older adult. And that's true, that's a really important reflection to make. So when we think about who older adults are, it's not just an age limit. Of course, we do give an age limit because that makes things simpler for research purposes, but it's really about function. It's about psychological, physical, social, and medical, so health, well-being. So it's all those things put together. In low and middle income countries, the World Health Organization says that can be as low as 55 years old. In developed countries, we often hear 70 years old as being sort of that guideline where you see a bit of difference in that functional ability. So that's something that there's not really a hard and fast number. And in a lot of studies, we'll say 65 or 60 as inclusion criteria, but that's just an important point to discuss. So why are older adults different, and why do we need to sort of pay a little bit more attention? So importantly, we know that 70% of older adults have at least one existing chronic condition. So for many, that's actually more. And we also know that older adults have historically been excluded from clinical trials. And that's important because if older adults are excluded and those with comorbid disease are excluded from these clinical trials over the age of 65, and yet those are the majority of people who actually are diagnosed with cancer, then there's a bit of guesswork that goes into providing treatment because the treatments have been designed for younger and healthier people. And you probably all know this. So this leads to changes in their tolerance, right? They're more likely to experience toxicity. They may be more likely to experience toxicity. Can also lead to inappropriate, inadequate, too much or too little management regarding their cancer. And although there are a lot of guidelines around the incorporation of geriatric assessment, in many cancer centers, the most common assessment practice is the eyeball test, which is not very effective if you're aware. So that's, simply me looking and saying, oh, they look good enough, or oh, no, they don't look good at all. So there is really a push, and I'm not going to talk too much about geriatric assessment today, but if you're familiar with this area, you'll know that geriatric assessment is sort of the gold standard to be able to really thoroughly assess people on those factors I just mentioned that all impact function. So coming back to sort of the complexity, we know that this is a complex patient population, and we all know that it's very difficult to navigate that cancer trajectory. I know Andrea was involved with writing the position statement for navigation for patients, for cancer patients. And so we have a complex set of patients who have complex needs, and then we also have a complex trajectory. So we've got compounding concerns here. So we've also read that the comorbidity issue is complicated because older adults are also more likely to get new comorbidities or new morbidities, new challenges during their cancer treatment. So this is escalating, right? This is getting to be a lot. So older adults are more vulnerable to morbidity, mortality, disability, and exacerbation of their comorbid chronic diseases during their cancer treatment. So what is self-management? Self-management is the ability to manage the disease, treatment, effects, and psychosocial changes arising as a result of illness, and it comprises several core skills and tasks. So essentially, it's the thing we expect people to be able to do. It's the thing we don't often ask about. It's sort of implied. The core skills and tasks are listed here: problem solving, partnering with providers, self-monitoring, risk reduction, decision-making, setting goals, and action planning. And the key tasks relate to the emotional, the role management, and the medical tasks, pardon me. And so if we think about self-management, consider yourself having a fever, or consider yourself having symptoms of COVID. How do you evolve, how do you use all of these different skills and tasks to sort of problem solve and navigate through that situation? Probably most people on this call are very well resourced and could think about how they would navigate through all of these different skills and tasks. You can probably think of patients that you've worked with or people that you know that would have challenges with many of these aspects of self-management. This is a really nice figure that was in a paper led by Doris Howell in I think it was the NCI, and it takes you through those skills and gives you some really concrete examples of what that might look like. So problem solving might include coping and stress management strategies, where risk reduction and health maintenance might include things like managing multi-comorbid treatment effects. And you can see that arrow on the bottom of the screen there says, core skill building is bi-directional and iterative to promote mastering, learning of skills and self-efficacy. So that's something to keep in mind. So the idea was self-management, and I'm cited here a report from Jack Kidd around chronic disease management that was published in 2012, is about giving opportunities to learn self-management may enhance understanding of illness, improve outcomes, and improve quality of life. Because without self-management skills, we're talking about older adults, but this can apply to anyone, you can't anticipate potential treatment side effects or engage in proactive behaviors. It's also important to consider that as clinicians, you or I may lack knowledge and/or time to support patient skills and application of self-management behaviors. How do we do this anyway when we're doing so many other things, or maybe we're already doing it? There's a lot of evidence related to self-management and other chronic diseases linked to improved parameters, for example, in diabetes, a change in hemoglobin A1C, and also that it can lower costs. But there's been less research in cancer, and there has been very little research related to self-management amongst older adults with cancer. So that's my interest. And I started to get interested in this area when I finished my PhD, or around the time I was finishing my PhD, so 2018. And at that time, I met Doris Howell and started working with her on a few projects and doing some postdoc training specifically around self-management with her work. And then for myself, really focusing on that older adult population. So what I'm going to talk about today is I'm going to present to you some research evidence about cancer self-management for older adults that can inform oncology nursing practice, and to think a little bit about, where I've come from and where this is going. And hopefully it's engaging. Those are my goals. So I'm going to talk about 3 studies that I've done in the last couple of years. So one is a priority setting session, one is a systematic review, and one is a descriptive study. So the first one I'll talk about is the systematic review of self-management interventions for older adults with cancer. So most of you on the call are, you've done some research, that when you're interested in a specific topic, one of the first things and best things that you can do is actually get into the literature and see what's been published on this area. So, as a person that was new to this domain I'd been exposed to geriatric oncology for a few years, working with the International Society for Geriatric Oncology. And I had also been working with Doris. And so I decided to conduct a systematic review to determine the effectiveness of self-management interventions for older adults with cancer, and to determine the effective components of these interventions. Because surely cancer is most common amongst older adults with cancer. Self-management is implied in cancer. So there's got to be interventions, and let's find out what's actually working. So we conducted a systematic review following all the usual guidelines. We conducted a very extensive search of 8 different databases and conducted quality assessments of these studies. So what did we find? Well, we found a lot of literature that was not relevant. So after screening 17,000 titles and abstracts, reviewing almost 500 papers, we found 13 full text papers which were included in this review. And so of these papers that we included, we focused on those that had an average age of participants age 65, or they were focused explicitly on older adults. And the majority of included papers were the latter. They were the former. They were not focused specifically on older adults, but had an average age that related to older adults. An average age of 65. So what we found was that all self-management interventions included in this review measured quality of life, which is important. That's usually the main outcome we look for with older adults with cancer. Other outcomes included mood, self-care activity, supportive care needs, self-advocacy, pain intensity, and analgesic intake, and only one intervention measured frailty. Effective interventions were delivered by a multidisciplinary team or nurses and mental health professionals. So in total of those 13 papers, only 8 of them actually were effective or had a positive outcome. The core skills that were targeted were problem solving, behavioral self-monitoring and tailoring, setting goals, and action planning. So that sort of gives you some ideas of what might be. So those are important, right? We all know those are really important features of self-management, and these are what are being studied so far. So those are things to keep in mind. And I think it's really important to note that there was an absence of focus on issues related to geriatric oncology, related to the concerns of older adults. And we always think about those 5 M's, which are mobility, matters most, mind, medications, and multimorbidity. So those 5 things, sort of like if you're thinking about older adults, I'm always looking for the 5 M's. I usually forget one of them, but those are the things that you want to be thinking about. And it's important to note that those were absent, but they were absent even in the interventions that were developed specifically for older adults. So keep that in mind. So what? So our takeaway from this was that, there's global calls of action to increase emphasis on self-management. Sorry for the typo there in the first line. And we also noticed that there are a few interventions that explicitly target the self-management needs of older adults with cancer. And that we would emphasize, or we would urge, that future work should focus on the explicit pathways to support older adults and their caregivers and prepare them to engage in self-management processes and behaviors. But essentially what that review showed us is that we have a long way to go. So the next study I'll talk about is this small descriptive study exploring complex self-management support needs of older adults with cancer and multimorbidities. So the rationale behind this study was really that, okay, so we see, and the systematic review and this descriptive work sort of went on concurrently. There's not a lot published specifically about older adults engaging in self-management that work. And in the work that I was doing with Doris, the qualitative work, we heard that coming through, this idea of this is hard work. Like, this is work. This is something people don't talk about, and it actually feels like I have another job. And that study that I'm referencing now wasn't specifically with older adults. That was just a general population. It had a younger average age. So, as I was doing that data analysis, I was just thinking like, okay, so if these, very capable folks feel that this is hard work, then how does it feel for older adults? Like, with managing many other chronic diseases, potentially having spouses who are ill, potentially having other caregiving duties, what does that look like? So in this study, we interviewed older adults with cancer and multimorbidity to understand their experiences of self-management while living with and managing another chronic illness. So I mentioned it was a small study of 14 older adults, and we also had them complete the multimorbidity treatment questionnaire, which is an instrument that's been validated to understand how people are managing multiple chronic diseases. So what did we find? We found that older adults really demonstrated a lot of strengths in engaging in self-management, but they also faced a lot of challenges. And really some of those key challenges related to the silos in our healthcare system. And as you can imagine, as I'm sure you all know, it's very hard to be able to coordinate multiple specialties, coordinate multiple illnesses when you have, when you have a side effect of your cancer treatment. Is it actually your COPD that's acting up, or is it actually from the cancer treatment? So we heard those sorts of narratives coming out. There were 3 main themes that we organized the data into, including situating cancer and aging. And so that was looking at the personal illness and caregiving experiences, enacting and engaging in self-management, and the challenges of living with cancer and navigating multimorbidity. And so we really heard participants talk about, sort of how their personal situations, their personal experiences with the illness all had an impact on how they could engage in self-management. And they also talked a lot about this idea of enacting and engaging in self-management. Like, there's lots of pieces that are part of it. And in order to be able to do it properly, it was work, right? That same idea was coming across. In terms of that questionnaire that I mentioned, we found that the majority of participants experienced no difficulty with the following tasks. So remembering how and when to take medications, collecting prescription medication, and monitoring their medical condition. Most participants felt confident with that. But nearly half of participants found the act of taking lots of medications to be extremely or a little difficult. And we know that when something is difficult, we are less likely to do it. We also found that seeing lots of professionals was found to be difficult, attending appointments was found to be difficult, and obtaining clear and up-to-date information also found to be very difficult. So if you're looking at these findings like I am from the perspective of, okay, we want to be able to do something to help this population. That's the end goal, right? We've looked at all the literature, we've conducted this small descriptive study. These are sort of getting down to some of these core gaps or things that are challenging. Limitations here, obviously this is a very small sample. Give us a little bit of an idea of what some of the problems are that we can get into in a little more detail with a larger sample. And so what? I think some of the narratives we heard were about that core role that oncology nurses play in supporting that self-management, but also in that they're filling the gap, right? So if we have participants who are really struggling, who don't have the resources, then they're very reliant on their oncology nurses. So having the skills as an oncology nurse and having some supports to be able to support that person to engage in self-management may be useful for oncology nurses. So, obviously, as I've already alluded to, this is a small sample. We need larger studies that can demonstrate this. So the last study that I'll talk about, I'm just going to do a time check here, is the Cancer and Aging Research Discussion Sessions. So what we did was we conducted community-based priority setting sessions with older adults with cancer and their caregivers called the Cancer and Aging Research Discussion Sessions. These took place in the summer and fall of 2019. Yes, that's right. Sorry, we are all in that sort of like COVID weird time thing. So that was 2019. What we did was we conducted 3 public meetings in community centers in 3 different communities. And we had 35 older adults who were living with cancer and their caregivers attend. And then we conducted follow-up interviews to discuss the priorities that came out of those meetings. This project is important to me. It was co-led with my patient partner, Margaret Thompson, and it also sort of incorporated or encapsulated patient-oriented research on a number of levels because it was co-led with a patient partner, but then we were doing this consultatory sort of priority setting process as well. So if you're into research methods, we can talk about that at the end. So what did we find? We found that there were clear consensus from participants on research priorities related to 2 key areas, and those were around enhanced communication and the need for tailored cancer support. And the 5 research priorities that we sort of came away with were the need for improved patient-provider communication, technology-based solutions, the desire for enhanced patient education strategies that really focus on multimorbidity and aging-sensitive needs, tangible and accessible survivorship supports, and support for carers and caregiver needs. I think it's also interesting to reflect on the fact that participants appreciated being consulted in the research process and shared key insights related to being a patient or caregiver, I should say. So what? So what are the takeaway messages? So future research obviously should try to focus on these key areas that are cancer communication and support. And really by capitalizing on older adults' interest in this research engagement process, we can work with them to co-create effective solutions to improve cancer experiences for older adults and their caregivers instead of doing for, doing with. So, what's the so what for oncology nursing and what does this mean? Again, to reiterate what I said at the beginning, self-management is a growing imperative, and the pandemic has really amplified that. We've really put people in their homes with the telephone in many cases and said like, okay, now we're here on the telephone, but a lot of that is taking place in people's homes. And I've put down here references to a couple of studies that we've been doing with older adults with cancer. And we don't have time to talk about that today, but if you have questions about sort of pandemic related changes, happy to talk about that as well in the discussion. We also know that older adults and their carers have distinct needs, so it is our duty to address them, and that certain older adult populations face greater challenges with self-management. So how do we address these equity issues? You know, I think that it's difficult. We're starting to have conversations about risk stratification, and, you know, certain people need more care, certain people need more support. And so is it a matter of sort of providing more self-management support to people who are more capable of engaging in that, and then, you know, being able to free up more sort of in-person support for those who are deemed to be at higher risk? Or is it sort of an across the board imperative? I think those are conversations we can have. And then the final point here is that virtual care is an option for older adults, but preparing them is critical. And this is something that we've seen in our pandemic related work in the articles that are cited here, but also in some community-based, larger population-based samples that we've conducted. It's the preparation piece that if older adults are prepared, they are, you know, they're accepting of this, but throwing them into it is not well received. And there is also a feeling that that they're missing out on something by not having in-person visits. So that's just something to chew on. So final takeaways from me, what I think is important about this. Older adults have distinct needs. I think I've said that, you know, at every different point in every different study and every different time point, and that there is a lot of heterogeneity amongst older adults. That's something we need to consider as well. Self-management is an explicit requirement of cancer care, but is generally unsupported. And we don't talk a lot about how to support nurses to do that work. So I think that's a takeaway to think about. And currently our systems, and I'm using the word systems very broadly, and resources don't consider the explicit needs of older adults and carers to engage in self-management. And, you know, I think on this final thought, I'll just say that, you know, in the work that I've been doing lately is trying to partner with community-based groups, because they're seeing a lot of the folks who are facing these additional challenges. So how do we connect all of these groups? You know, we have geriatrics, we have primary care, we have community-based groups, we have home care, we have acute care, we have cancer, you know, the cancer agency, we have cancer services that are administered through the community. How do we bring all these things together to actually support older adults? Easy task, right? So that's the thought that I'll leave you on. And, you know, that's a very kind of high level overview of all the work that I've been doing the last couple of years, and really happy to answer any questions you might have.
Great. Thank you so much for that, Kristen. That was a fantastic presentation. And as you got to that last slide there, it got me thinking about sort of that systems issue, and that where is the solution to this problem, and how we can mobilize to better support our patients and meet those needs of this older adult population, and to better self-manage during their cancer trajectory. And initially, as you're talking, like my head was going to, maybe the answer lies with those community-based programs and linking them better with the system. But I think they're all systems, they're all disparate systems that we're trying to find a way to connect between the cancer agencies, the hospitals, the community-based programs. And I'm rambling on a little bit there. But I guess my one question to you, just to start off this sort of discussion period portion of the call today, is what do you think the next best step would be if we were to try to look at that, to address that in trying to address that sort of systems problem that we have?
So we're doing it. We just got some funding to do it, and we're trying to do that now. So just have key informant interviews and as well as interviews with older adults to sort of see from both perspectives, you know, what are all, not like kind of like journey mapping, but not really, not quite that methodology. You know, we're calling it a qualitative environmental scan to see what's going on with these different populations. So having sort of the older adults' perspectives and being able to kind of inventory all the services that they've used and try to, you know, have a really diverse sample of folks who are more frail, less frail, those who have more or less needs, lower or higher needs. And then looking at having interviews with, you know, folks in geriatrics, primary care, you know, in the north, in the interior, on the island, and trying to sort of identify some of that work. So we have a plan. We'll see.
It's just a matter of actioning the plan now, right?
I think the more,
yeah.
Sometimes
Great. I'm just noticing Sally has posted a question in the chat for you, Kristen. So it says, since the older adult is the dominant population in the cancer care system, and most of the available research has been based on examples that are primarily older adults, how do we distinguish these older adult findings from all of the general guidance around caring for cancer patients that we have built up without thinking of it as age specific?
Yeah, that's a really great comment, as always, Sally. Thank you. I think this is a real challenge, and I think that for many of us who sort of end up doing research that's specific to older adults, it's sort of all of a sudden like, oh yeah, like duh. It's, you know, all the research that I've been doing has been with older adults, and yet it's not very specific. It doesn't really focus on the specific needs of older adults. So I think that's a really tricky question to answer. And I think around some of the treatment stuff, we have to look at some of the exclusion criteria, because a lot of older adults have been excluded from research because of the things that I've mentioned, particularly intervention work, the sort of comorbidities and age have been exclusionary criteria around treatment related research. But I do agree. I think it is hard to sort of untangle that. And I think we can do that by, you know, looking forward and being more deliberate with the work that we do, where we are intentionally looking at the specific needs of that population. I don't know if that's a good answer or not.
All right, so just monitoring the chat here again, Lorelai's commented, thank you for the excellent presentation. I'm wondering if you have any thoughts based on your research so far about the implications of chronological age versus biological age in our practice. Ooh.
No, I don't. I don't have anything intelligent to say about that. I think just that it's really important. I think obviously geriatric assessment is extremely important, and even the little small types of work we can do, like Schroeder Satar and I have been doing a lot of work together around, you know, mobility interventions. She's got a paper coming out in CJON around, you know, 2-minute clinic assessment of mobility without even telling the patient you're doing it, right? Because falls amongst older adults with cancer are so important. And we all know falls can have huge implications. And yet in this international survey that we did, we found that most people don't ask about them. And why don't they ask about them? They don't ask about them because they don't have resources to support older adults if they do find that they have had a fall. So that's obviously a lot to unpack, but that's not a surprise. Like I've heard that in other research as well, where we hear nurses not wanting to ask about specific things because they don't feel supported to actually deal with the answer if it's something that, you know, they don't have the capacity to manage. So, I've sort of evaded your question, but I think that's just an important thing to think. But not my area of research. You know, geriatric assessment is the best way to make that differentiation. That's my answer. I'll look at Scott's question.
Yeah, well, you look at that. I'm curious to know, I guess if any work has been done, and maybe it's more a question back to Lorelei then, or maybe to you as well, Kristen, you know, if we think about chronological age versus biological age, would it in any way alter the self-management for older adults, depending where that magic number lies? Because I think you mentioned at the start that the actual definition of an older adult with cancer, was it 55 and over?
No, I mean, there is no specific age in geriatric oncology. The International Society of Geriatric Oncology says 70, but in low and middle income countries, they'll say 55. You know, there's a lot of range. 65 is usually the most common number we see, but as Caroline Mariano often points out, that's like based on, you know, that's based on the retirement age, more administrative, not super useful. And there is such variation amongst older adults. I don't know if there's a magic number. I personally think it has a lot more to do with multimorbidity. I think that is the big thing, right? That also tells us a lot about health. And with multimorbidity comes changes in functional status typically, and also medication management and potentially mobility. So it can pull some of those other factors along with it. for me, that's really my area of interest. And I think that it's the multimorbidity that drives the complexity. And yeah, that's kind of my, yeah, that's my interest.
Yeah, that's a great point. Yeah.
That sort of messy web. And it does make it so much more difficult. And it's funny because I had this on a slide from a presentation I gave on Monday to BC Cancer, is that, you know, older adults were saying about this COVID research, they're saying, yeah, so virtual care, like, it's not my preferred. I understand why we have to do it. I really would rather be in person, but if we're going to do it, why don't you get all my specialists together on the line with you too? Like, if I'm having this experience, why can't you really leverage this technology? And I think that's just like, yes, that's the answer.
That's really interesting feedback. I think that clinicians need to hear and it's a really excellent question. Why aren't we leveraging the technology to really truly meet their needs and at one appointment versus 4 or 5, right?
And then everybody's on the same page, right?
Yeah.
And it's not complicated. Like, the technology we're talking about here, people, is a telephone. Like, this isn't rocket science, right? And, you know, those are the sort of things that during the pandemic that people have been like, you know, how do we facilitate caregiver involvement? Well, my caregiver sits in the parking lot on their phone and teleconferences into the appointment. That's not super high tech. And yet it's the caregiver who's 80 years old who thinks about it, not the clinicians. It was their idea. They're the ones who came up with that idea. So I think those things are, you know, important, and we need to think about how we can just, you know, it doesn't have to be complicated. It doesn't have to be a $5 billion software update. We can use what we have, right? Make do.
So I guess it could be said almost that we could probably do better as oncology nurses in helping patients to self-manage by listening to them and their ideas on what self-management could look like.
That sounds like a great idea.
Because realistically, you make a great point. It's the caregiver or the patient that's coming up with the idea, but yet we don't seem to be come up with those ideas. So maybe instead of asking each other how to do this, we should be asking the patients more. But I'm digressing, and we haven't gotten to Scott's question yet. That was kind of my thought for the day. So Scott had asked, I wonder if you could say a bit more about the caregiving experiences related to situating cancer and aging in your qualitative work. What types of caregiving experiences came to the surface in your analysis?
Yeah, so that was really interesting. And again, I won't do a disservice to the participants because you know, by saying it is a small sample, but it is in the paper. The paper is, I just proofed it last week, so I think it is out now. And I think the reference was on the bottom of that slide, but I'm happy to share it with you. The caregiving experiences are really, like, heartbreaking, I would say. Like, you know, I remember I interviewed one woman who was, I think she was 80, and her partner was 80, and they both had a lot of comorbidities, and he was driving her to the treatment center, and he would fall asleep in the chair, and then, you know, sometimes he was too ill to take her, and it was, like, really hard to hear, really hard to hear. But those are quite common situations. She was lucky to have a caregiver who was able to take her to her appointment. She felt really lucky too. But then, you know, she was also caring for him because he wasn't super well. That's one really poignant example. Another one is, actually, she ended up being one of our co-researchers, and those studies were not in chronological order. But she ended up being one of our session facilitators at the priority setting sessions. She was diagnosed with colorectal cancer, and her husband was diagnosed with dementia at the same time. And he declined very rapidly, and she was getting chemotherapy, and she had to put him into a nursing home. And it was just this sort of really heart-wrenching stories of you know, okay, so she's trying to manage, right? Like, that's what we're trying to ask her about. Like, how did you manage your cancer diagnosis? And it's like, well, yes, I had my cancer diagnosis, but I also had this unwell spouse. So there's also all of that to sort of unpack with it. So multimorbidity, I think, is a big one, but it's also sort of the family system as well is playing a huge role. So those are sort of the two most memorable that I can think of. Scott, did you have a specific question?
no, I think that broad overview is helpful, and I'll definitely seek out the paper now that it's in press. But I think that the piece that's really interesting that I'm taking away is the often when I've been thinking about caregivers in the context of this talk, I've been thinking about intergenerational caregivers, but the complexity there that I'm coming to hear more about is when your caregiver also has multimorbid conditions and is perhaps of advanced age, and some of the unique complexities around caregiving that would exist in that context.
Yeah, and I think that's a growing area. I was co-supervising a master's student at McMaster who was looking at caregivers who have cancer, older adult caregivers who have cancer. So they themselves were the caregiver to someone else and were diagnosed with cancer. And she's taken a leave of absence, but it is a very interesting kind of question. And I think maybe one that we're going to see more of. So the intergenerational piece is interesting. We heard less about that, but there's also a whole thing around people not wanting to burden their kids have kids and they're busy taking care of them, and they don't want to kind of do the sandwich thing. They don't want to put extra pressure on them. So that was something from an intergenerational perspective. That's something that we heard about. Yeah, thanks, Scott. I'll look at Jennifer's question is a long one. I'm not able to parse it here, so I'll take my time to read it. Yeah, that's a great question, Jennifer. So I would just say, typically in the research that I've been doing, I'll either use 65 or 70 as the age for recruitment, and I reference the literature about why I think that's important. I think, especially in the multimorbidity research, again, I think 65 is okay if you're saying they have a chronic illness plus they also have cancer, because you start to see some of those additional challenges. So I would say younger is okay there. I know that some folks that I work with prefer the age of 70. And, if you're not looking at comorbidities, yeah, I mean, there's lots of folks who might be super healthy. And actually, we have developed a patient advisory board. And this is actually one of our challenges, is that we're getting a lot of like uber healthy, uber high functioning, like 70-year-olds who've had cancer, and they're like out hiking on the weekends and can probably run a faster 5K than me. And it's really challenging to get, and I can't probably even run 5K, I'll just add that. And it's challenging to get that sort of representativeness, and frailty, functional status, multimorbidity, those are really important things. And actually one of the older adults who's on our advisory she is on because she has had cancer. She is in her 70s, but she does not see herself as being on the panel as a person with cancer. She sees herself being on as a caregiver because her 90-year-old mother died of cancer. So that's interesting, right? It's also about the personal sort of interpretation of how you see yourself. In terms of the second part of the question about cancer occurring within 2 years of retirement, I haven't done any specific work around that, so I can't really comment on that. Of course, you do hear those really horrible stories of someone sort of retiring and the next day or shortly thereafter having cancer. And that's something that has been really interesting with the COVID research we've been doing, is how COVID has had such a big impact on these older adults who have recently been discharged from cancer care services. So they've been discharged within the last year, so they're new survivors, and then the pandemic happened. So it was like they just finished cancer treatment, they were going to go on trips, they were going to do all these great things, spend time with their grandkids, and then this sort of happened. So that totally doesn't answer your question, but just a related thought. Thanks, Jennifer.
Yeah, great questions and dialogue, everyone. And I'll just throw out there too, for those of you that are online, don't feel shy. You can come off mute and jump into the conversation as well. I don't know. I guess for me then, any final thoughts or recommendations, Kristen, on what the next step for, say, oncology nurses working in direct care could be? And then maybe as well, you know, those in leadership positions on how to almost switch the narrative a little bit so that we can get some traction on moving this work ahead.
Yeah, so those are great questions. And actually, I've been thinking more and more. I mean, there's only so many hours in the day, and there's so many grants that I need to write, and they don't write themselves. But there is definitely something there around nurses understandings, nurses' understanding of self-management and enacting self-management, and what is self-management? Do you care about it? Do you think about it? Is it just one more thing you have to do? I think that there is, maybe that's a nice master's project for someone. But I think that is a really, I think that those are some good questions, and specifically as they relate to older adults. We know that folks feel unprepared to support that. So that's one thing. I had a grant from the Saskatchewan Health Research Foundation, a large grant to do this really big multi-site study around looking at sort of the care trajectory of older adults and their self-management across 6 months. So, pre-diagnosis, and actually my funding had to stay in Saskatchewan. So I'm not able to do that study, but that's something that I have the grant written. I have, my partners in place. And so that's really something that I want to do. I think that is sort of an important piece that needs to be done. There's been a recent study in multiple myeloma patients with a similar design, but I would like to do that study. And then, of course, I think that there's really a lot of opportunities for that intersectoral, cross-sectoral work to sort of look at, I was talking to someone recently from the Japanese Seniors Center on a project that we're working on. And she was like, we've got a lot of folks who have cancer, and we're supporting them. Like, these are all the things that we're doing to help them. And, then I'm talking to another seniors group, and then I'm talking to the Jewish Community Center, and they all have these sort of programs that they're doing. So I think it would be really helpful to have an understanding of not looking at this just as a systems issue or a BC cancer issue, but looking at it more holistically. What are all the resources that folks are using? So that's sort of those are my next projects that I'm working on, and then we'll see.
That's great, thank you.
But I just wanted to thank you for the opportunity to present today. It was really, nice to be able to come, and I'm new here, so feel free to reach out to me if you're interested in working on anything. If you have any great ideas, if in your clinical setting you want to do something, I'm here and I'm ready to help.
Well, I think that's fantastic. And I think there's, a world of opportunity for work in this area in BC. And so, yeah, I'm just looking at the chats as well. And I think everyone is very grateful for your presentation today and for sharing your work. And yeah, I agree. I enjoyed this very much, Sally. So thank you so much for doing this for us. And I think Lorelei had a comment here as well that she really enjoyed your caregiver article that's in press. And I'm wondering if you'd be okay, Kristen, if we circulated links to your publications to the members when we send out the recording link for this presentation.
Yeah, I can do that for sure. Yeah, I can send those to you.
And so I'm going to do a last call for questions or comments. Does anyone have anything they'd like to say before we jump off the call today? Great. Okay. Well, without further ado, we'll give everybody their 6 minutes back. Thank you so much, Kristen, for sharing your work with us today. It was fantastic. And yeah, we'll be circulating the link to the recording once it's up on our new YouTube channel as soon as possible. So keep an eye out for that email and with links to Kristen's articles. So thank you very much for joining us today, everybody.
Thank you all.